If our patient is asymptomatic, which she was, and has only the de novo metastatic disease to the bone that we talked about without having significant pain. So you might recall that we detected her suspicious bone lesions that were then biopsy proven just because we did a CAT scan and a staging workup. The patient did not present with those symptoms. So I think my therapy would still remain the same with a CDK4/6 inhibitor with endocrine therapy for this woman. That actually brings us to a very common question that we want to answer in clinic when we're seeing a patient with first-line recommendations of treatment for metastatic disease. When we really think that the patient is in visceral crisis, so when we talk about patient as being symptomatic, are we talking about a mild cough? Are we talking about some shortness of breath? Or are we talking about a woman who's significantly short of breath, has significant difficulty with cough? We're seeing that her vital signs are being compromised. She's having difficulty breathing or maintaining her saturations and room temperature. Then we're thinking about perhaps giving them chemotherapy, thinking that maybe chemotherapy might have a faster effect. But short of that, if a patient does not present with visceral crisis, meaning with a significant disease burden or a lot of symptoms or lab abnormalities that go along with those symptoms, I think it's very, very appropriate to treat this woman with a combination of a CDK4/6 inhibitor with endocrine therapy. We treated this woman with fulvestrant with ribociclib in the first-line setting. So if this woman were to progress, at that point, I think it would be very appropriate, should she not have any significant disease burden with a lot of visceral crises, to continue to treat her with endocrine therapy. And you could use and justify the combination of exemestane with everolimus or tamoxifen with everolimus based on the results from the Bolero-2 or the TAMRAD trial, and treat her in the second-line setting with that combination. In fact, when you look at the NCCN guidelines, they suggest that a woman with ER-positive metastatic disease can be treated with up to 3 lines of endocrine therapy before you have to resort to chemotherapy. Certainly, if there was an appropriate clinical trial option available for her, I would be gladly enrolling her into that clinical trial and reserving exemestane and everolimus or tamoxifen and everolimus in the third-line setting before I had to resort to chemotherapy. We have come a really long way. So we used to treat our postmenopausal women only with aromatase inhibitors. And now we have data for CDK4/6 inhibitors with aromatase inhibitors based on the randomized phase 3 trials that all unanimously have shown an unprecedented benefit in progression-free survival for these women. We do have an important trial that we're awaiting the results from, which is comparing fulvestrant with a CDK4/6 inhibitor, in this case palbociclib, compared to aromatase inhibitors with palbociclib based on the Parsifal study. And hopefully that will also shed light into whether there is a very appropriate and the best endocrine therapy partner that we should certainly be thinking about in the first-line setting. But until then, I think we definitely have a lot of data, one, to justify CDK4/6 for our patients in the first-line setting, specifically with aromatase inhibitors and now also with fulvestrant.